Welcome to the Myopia Masterclass. In this instruction course, what we like to create is some awareness about how myopia management is like another important tool in your ophthalmology practices. So how we want to go ahead with this is we would start with effective communication with parents. So first is the parent counseling, patient engagement strategies for myopia, practice workflow optimization for myopia control clinics, myopia control marketing strategies, community outreach and school-based myopia screening programs, and integrating telemedicine into pediatric myopia care. A few of the speakers have had to leave early because of their flights. So we'll be running their talks parallelly. Thank you. Which one? Shruti's talk will start first, huh? Yeah. You want to start this one? Okay.
Hello everyone, and thank you so much for the opportunity to present here at AIOS. I apologize for my physical absence there, but I wish to make it up through this video seminar on patient engagement strategies for myopia management. Now this is a slightly different IC where we focus on different aspects of myopia management and especially the practice-oriented aspects. I will be talking about why we need to engage patients. First, let's answer the question, what does patient engagement actually mean? It primarily is a patient-centric approach. Now, we are all used to the kind of approach wherein the doctor has his point of view and his recommendations, and the optometrist and the entire team works towards in that goal. However, when we slightly change our perspective towards a patient's point of view and a patient-centric approach, we can actually change a lot in our practice flow, which can engage the patients in a much better manner and create much happier patients and much better outcomes. So as I was saying, why do we need to do patient engagement strategies? One is to improve health outcomes. Patients who understand better and who are a part of an efficient process actually have better health outcomes. The second is enhanced patient satisfaction. Now, patients who have a much easier process to go through to come for such a chronic and long-term disease, ensure that they are satisfied and they give you positive reviews. The third is there is a significant reduction in indirect healthcare costs when incurred by the patient, as well as flow-based costs incurred by the system itself. So there you go. That's why we need to engage patients in a more healthier manner. Let me go through my practical aspects of what I do in my clinic and 5 areas where I engage patients, and maybe through this we can have an interesting discussion going on. So the first and the foremost is in the clinic. The most important in the clinic is to have an efficient system. So we need to make sure our protocols for work flow are optimized, and I think Dr. Jitendra will be talking about that, so that an entire myopia workup and from in to out time is reduced to probably an hour or less. And the second thing is training. I train my optometrist to counsel about myopia strategies, to talk about myopia lifestyle modifications right when they start seeing. So there are 2 important people in my clinic. One is the optometrist and the second is the counselor, the person who finally they see. These 2 people have a ready-made script which they actually follow to see whether a checklist is done, whether they have spoken about all these things, and whether they have also imparted the knowledge of other possible options to the patient as well. The third is the questionnaire. Now, this is something that has worked well for me. That is, whenever we do this myopia workup, it takes a considerable amount of time. And during that time, to engage the parents, I give them a questionnaire which is through a Google link. Now, this questionnaire is about a 30-point questionnaire, which takes about roughly 10 to 15 minutes for the parents to fill. And some parents are quite engaged with filling that while the workup is being done. So this is an interesting way to engage parents while while the children is getting checked. The fourth is to ensure the room has enough amount of infographics and videos. And in terms of flow, what I recommend to my patient is when a first patient comes and gets diagnosed as a new myopia, I always keep my days of myopia clinic on Fridays and on a different clinic on Mondays and Tuesdays. So 3 days a week I run my myopia clinic, and any other patient who comes on any other day gets checked, but they are always sent an appointment for those 3 myopia clinic days. Now, the advantage of having to come back for those days is, one, they are monetarily prepared to have the myopia workup done. Two, they are mentally prepared to spend some time in the clinic rather than being hassled for time in their original visit itself. And the third is, that day there are enough number of myopia patients, so actually giving them information is much easier. So I always fix an appointment on another day for the myopia clinic. Of course, my follow-up patients always know the dates of the myopia clinic and come on those days. So this is how a myopia clinic looks, and you can see that this is how the mascot that we have designed. So here you can see this is how the refraction room is. This is a separate refraction room. This is my optometrist explaining the situation here. We have a separate logo and branding for the myopia clinic, and our mascot is there quite visibly everywhere for the patients to kind of see what's happening in the myopia clinic. I also have comic books scattered across in the clinic so that the patients can read and get more awareness about myopia and spectacles per se. Now, this center, what you see is the workflow pattern that I actually follow in my clinic. So you can see that this proforma is printed out across all my centers, and they all have to follow this checklist. And towards the end, you can see that questionnaire, tick if done, WhatsApp group support, tick if done, graph, and that's the myopia journal that we give our patients, tick if done. Now, this is a proper checklist that the optometrist actually goes through and fills it up so that they know that everything is done for that patient. And these are the kind of explicit information that's available at all points in the clinics, and this is something that I have inside my clinic, inside my doctor's consultation room, that actually patients and the parents can read while I get their child checked up. Now, while they are in the doctor's room, I spend a lot of time listening to the patient to make aware of their choices, and sometimes it may be seeming that they may not understand scientifically, but believe me, if we explain scientific terms in a really simple manner, patients do accept, and their acceptance to higher myopia strategies actually take up quite well. The second and most important thing is to have shared decision making. Now, this is something very important, and I think Dr. Aloka may be touching on that. It's important for the parent to be a partner in your journey for myopia, and I always do not say that this has to be done. I always give them two choices. Of course, I always tell them I recommend this choice, but it's up to you to take the other choice. That's your choice as well. I tell them the pros and the cons, and the decision is finally taken by the parent, and that's extremely important because then they become responsible for that journey's process as well. The third is to have a personalized approach. Now, how I do this is, once we decide that, okay, the myopia is progressing and we need to do something about it, I tell them about these strategies, and I tell them, you have this choice, you have the orthokeratology, you have the spectacle lenses or the low-dose atropine. I tell them about the pros and cons, and I tell them for her or for him, this may be the ideal choice, and I explain why that may be an ideal choice. I also go through the Google form in the clinic in front of the patient as the patient is sitting there, the Google form that the parent has filled in during the waiting time. Now, that helps me kind of see what their lifestyle is and quickly make decisions based on that and give them a personalized approach. Like I ask them, listen, you have classes till 4:30. Now, what are you doing from 4:30 to 5:30? Just add a sport there. Where do you live? Do you live close by to a sports arena? Then you go to visit a sports arena. Some children say they like the morning. So I tell them morning, go for one round of sport activity, then go to school. So you kind of personalize it right then and there in the clinic based on the Google form. The fourth is gamification of goals, which means that when they come back and they have reached their goal or they have spent that much of time, I always reward them with something small like stickers or some little things that don't actually matter much to us, but it matters a lot to them. So just to show an example of that, you can see that this is how we have the lenses in the clinic that can actually, the patients can see. I do show them about each strategy, like myopia, there is a orthokeratology session, this is how it looks. I do have my trial set right in the clinic, so I show them this is the orthokeratology trial set, this is the EDOF trial set. So you can visually, they see what's there and then they get to make more informed choice. And of course, this is about the shared decision making. So you can see there are different levels of how a parent would react, but I always ask them to be a part of the healthcare team and also to be their own health advocate. The child has to be responsible for their own health behaviors. So why this helps is because they do not complain if a strategy doesn't work. Like if something as expensive as spectacles or orthokeratology doesn't seem to be controlling, they know and they take responsibility because they know it's a disease that involves lifestyle plus all our genetic and our whatever strategy that we're using. So upon leaving the hospital, the most important is I give them a myopia journal, which I will be showing you. I ask them for a good Google review. I would ask them what channel they like to be updated. Is it SMS, WhatsApp, email? And then as per that, I kind of fit them into that group. And I also send them regular protocol and reminders. I also ask them which school they go to, because sometimes you can get a link from the school and we can visit the school for school screening program. Now this is the myopia journal that we see. You can see this child has been following up consistently from 22 to 24. This is how the journal looks, and this is the kind of gamification that we do. We give little stickers, we start them on little things, and then this is a sticker box that I have that helps them kind of gives them a little bit of boost. I also add them to the myopia support group. This is the Google questionnaire I was talking about, and for better workflow optimization, I give them a myopia, we have a myopia clinic website, email ID, where we have this kind of a Google sheet where everyone fills in what are the number of advice and orders done, and then they also have this kind of a follow-up, and we make sure that a Google Calendar is linked to the date that they have reviewed, so that their next review pops up on our screen for the optometrist or the counselor to make phone calls and remind them every 6 months to come for their review. We also give them recall engagements like events, appreciation, Q&A sessions. This is the recent one we conducted, which is a selfie with sun contest, and we gave out certificates of appreciation. These are the kind of pictures that these children sent out to us. It's really interesting. The children, once they are engaged and they know what is good for them, they really get into the flow. This is one such event where we had this kind of a get-together of children with myopia, and we had these kind of interesting activities. It's also important to have some key metrics in our clinic, like patient appointment times, whether we are having good appointments follow-up, whether there are no shows, how many appointments are there, what is the wait time. These are feedbacks that we need to keep going back to improve the efficiency of our system. So there you go. This is the last slide. This effective patient engagement strategies involve the pre-visit, during visit, post-visit, and ongoing. So pre-visit, good information, appointment reminders. During visit, listen actively, involve in shared decision making, and set goals for the patient. Post-visit, have a timely follow-up with reminders, and as an ongoing, keep getting patient feedback, and include the use of technology and automation to make all of this process much easier. So thank you so much for your patient listening. I know that systems and processes are essential to keep the crusade going, but we should never forget that the crusade is the most important. Thank you so much. You can contact me on this email address and phone number. And thank you once again for this opportunity at AIOS.
I think Dr. Shruti has extensively covered the entire patient engagement strategies, and her tips in her own hospital look very exciting, which we can take back home. Next up is Dr. Jitendra Jethani. He needs no introduction in pediatric ophthalmology world, and his topic is practice workflow optimization for myopia control clinics.
So, thank you so much. I would be speaking mainly about how to see the patient, what to do when the patient comes to us. When we see that this is a particular patient who is having myopia, we have to do some baseline investigations and then see whether he's progressing further or not. This I think will be taken care by other speakers, how to start or set up a myopia control clinic. But since I was talking about it, I thought that there should be some few points on that. And this is the workup which is taken from the AIOS guideline for myopia progression control management. We came up with this, I think it has been like now 3-4 years. So these are some of the investigations which are in the must do, good to do. And I think that most of the investigations which are in good to do have been shifted into must do now. So I would be showing that also. So this is the first step. I was just talking about the similar things. First step is to take the history and first of all get the risk factor analysis as to this particular patient may have a progression. We are not starting the treatment strategies in these particular patients, but these are some of the patients who may progress into go for myopia progression. Younger age, if the patient has young and has started developing myopia, parental myopia, sibling myopia is there. There is a history of lack of outdoor time. There is excessive near-based work, and there is a history of fast progression. So these are some of the things, and then we come to the second part of it, that is the diagnosis. Diagnosis, we all are ophthalmologists, we are doing our work fine since years, we know how to do a cycloplegic refraction and prescribe glasses. The part 2 is that you have to do a baseline K, baseline axial length, do a good fundus evaluation for myopic patients, and corneal thickness if it is possible. So these baseline investigations are important because these would actually tell you whether myopia is progressing and how it is progressing, whether the axial length is actually changing or not changing. So who is progressing? This is very, very important, and how much progression is actually significant. So myopic progression is actually defined as a progression of glass power by more than 0.5 diopter over a year. In terms of axial length, in our clinic, we define as a progression of 0.2 millimeter beyond 14 years, because past 14 years, we do not really think that there would be a great progression. So even if there is a small progression of 0.2 millimeters, we take it as a significant progression. Under 14 years of age, 0.3 millimeter progression is what we take it as a significant progression. So otherwise, there should not be any change in ocular biometrics. There is a small point of pre-myope. The pre-myopes are nothing but they are not really myopes, but they are like very small myopes or emetropes who may have a history or risk factors, sibling myopia, parental myopia, or there may be a history that they have been progressing axially. So there is a history that they have been having axial elongation, and that is mainly because they have other risk factors. So if there are risk factors and if you have evaluated these children as progressing, you can take them as pre-myopes. The key point in all this gamut is myopia progression. So these are our recommendations that which we follow at our clinic. Pre-myope who are non-progressor, you don't have to do anything. Even if there is a history of sibling myopia, parental myopia, you just have to wait and watch for the progression to occur. In the meantime, the most important intervention, most powerful intervention is behavioral changes, outdoor activities, less near work, less screen time. That is the most important intervention that we can do when there is no progression and we want to stop any other progression that can happen. Pre-myopes, if there is a progressor, if there is a history and you have a backup data that this particular patient was plus 0.5, has become emetrope and is already minus 0.5 or minus 0.75, and there is a serial increase in axial length, you can definitely think of some myopia management strategy. And if there is a myopia progressor, we would do certain investigations like accommodative lag, peripheral refraction, and then think of two major strategies, which are either low concentration atropine or peripheral myopia, peripheral hyperopic defocus glasses. Just a minute. Yeah, so this is more or less our strategy of first line treatment. The only reason I'm not here to discuss really about atropine. The lecture is more about what we do in our clinic, more of what we practice. So the most important thing is that we follow them up. After a month, once we prescribe them drops, we want to see whether there is any increase in pupil size or not. We check their accommodative lag. We look for any binocular abnormality. We do the cover test after giving 0.01%. There have been cases reported where patients have developed esophoria post 0.01% because it suspends the accommodation subnormally. Not really, it completely removes accommodation. At 3 months, we would again check the visual acuity, pupil size and compliance. We would check the compliance at 3 months because पहले महीने में तो everybody is really into it that myopia हो गया बच्चे को, we will do something about it. By the end of 3 months, everything sort of gradually goes down. So we have to do a compatibility check. We have to do a compliance check whether patient is actually putting the drops or not. And at the end of 6 months, we will do check whether there is any behavioral modification, reduced near work or not, outdoor activities, and repeat cycloplegic refraction, axial length, baseline keratometry. This is another intervention. My focus is more on the follow-up schedule and evaluation. So once we prescribe peripheral defocus lenses, be it Hall lenses by Stillest or Zeiss Care lenses or DIMS lenses, we call them back again after a month and we see whether they have any problems in the visual field, because the central 9mm is actually the clear zone and there is a peripheral defocus. There are plus 3.5 to plus 6 lenses depending on which particular glass we are choosing, and at 6 months we do all the battery of investigations. So this is the summary of the whole workup that we do at our myopia control clinic. The first part has the history and then there is evaluation. Then we categorize them whether they are a progressor or not. So the key, as I think I have been repeatedly saying, is that the key is whether there is any progression or not, and if there is a progression, then we think of what would be the appropriate strategy. But we have to see the axial length, K reading, accommodative lab, and binocular vision status, cover test, just to see that we do not increase or increase or start any other new anomaly. So that was all regarding the workup. This is mainly about pre-myopes. Who are pre-myopes? There is no set management, but these are certain recommendations that can be done, not really part of this is so I mean, you can, if you want to take pictures, you can take when to initiate anti-myopia therapy in myopes. These are some of the recommendations that we do, and most important is to note progression and then think of appropriate anti-myopia progression strategy. So that's regarding workflow optimization.
Thank you, Dr. Jethani, for a wonderful talk. I think we can all follow this in our clinics. Now I would request Dr. Aloka. She is a practicing pediatric ophthalmologist in Hyderabad. She'll be talking on effective communication with parents, how we address the myopia concerns.
First one.
Dr. Aloka.
No. First one. Pehla wala.
So while ma'am is setting up her slides, I have a question for Dr. Jethani. So what role does orthoptic or accommodative lag, do you check in every patient, or when does your patient go to the orthoptician and get his convergence and everything checked?
No, we check, we will do a binocular vision status check in all the patients. We will check NPA, NPC in all the patients. Accommodative lag, I do it myself because it just takes a minute and it is not really difficult. We check it. So typically when the patient comes for the first time, we don't check accommodative lag. We do a cycloplegic refraction, we do a PMT, or we give glasses. We do a duochrome and we give them glasses. Once the patient comes back after a week or 10 days with glasses, we check the fitting and then do accommodative lag. And we just note it down. At that point of time, we are not really sure that this patient would be progressing. You would be surprised to see in your own OPD, there are almost 30 to 40% of the children who do not progress even otherwise also. So there is no point in jumping to the gun that, you know, this child has got myopia and we have to give him atropine 0.0. Just wait and see whether there is any progression or not. Why it is important is because it is like, you know, seeing a 0.6 CD ratio disc and giving him anti-glaucoma drug. So we have to first establish that there is a disease process and then treat disease process. In the absence of myopia progression, we really are not sure what we are actually treating.
And one last question, any condition, like you said, you won't start a therapy in first go, or you won't do, but is there any condition that, or any requirement that you feel I should start on the first visit itself?
No, there has never been a pressing engagement like that. If you have any, you can, or Rashina has any comments.
No, really, I also see first document progression and then basically start on the myopia control options, not on the first visit.
Yeah, correct. So just to highlight that, please don't start it on the first, just because if you see a myopia in your clinic, look for progression and then start.
So my talk today here is effective communication with parents. And as pediatric ophthalmologists, most of our time is spent in counseling. And parents being a very important caregiver for the child, they are equal or more partners in patient care. Slide. Now, I mean, this is just to touch upon why, and why is all this discussion so important. Like we have already seen, myopia is a rising problem. By 2050, more than 50% of the world population is going to be myopes. And this is a very important paper by Dr. Rohit Saxena and group, which showed that there was a high percentage of myopia, especially in urban India compared to the rural India. And why are we worried? Of course, we all know all the complications that can be associated with high myopia. But do we counsel this to our parents? No. So, this was an extensive study done in Ireland, where they saw what is the parental attitude if the child gets myopia. Now, most of these parents saw it as an optical inconvenience, a higher expense, or a cosmetic inconvenience. And they found they was very nonchalant about myopia as a health risk. This means the education is still lacking. But it's all about love. I don't think the parent doesn't love the child. They're just not aware of what to worry about and when. So, first of all, when a child comes to you and the parents are sitting right across you, let them digest the news. For a first time parent to have a child wearing glasses at say 4 or 5 years of age is quite a big news. And so letting them digest and not wanting to counsel somebody who does not require counseling at that time is very important. Another important is when, where, whom to counsel. Now, many a times we see in our clinics that all these children come with like multi-generational, like there'll be some aunt, uncle, there'll be parents, there'll be grandparents. So there'll be 6, 7 relatives. Now, you are not going to be sitting with all of them and telling all the information. So find out who are the primary caregivers for this child. Sometimes a parent is staying in the village with the grandparents and they might be much more important chain in the management of this child. Also, I think give them time. If you feel that everybody is quite hurried today, then do not do the counseling. Call them again to further counsel about myopia. So this is something that I do. Keep the child engaged. The child doesn't need to know too much right now. So keep the child out of your outpatient. Once your checkup is done, let the child play, read books while you have your staff babysitting them, then counsel the parents inside, because then they can really concentrate. Effective communication, what is important is it has to be first sincere. You can't put in so much fear. You can't say your child will have a retinal detachment, so let's do something. Have long-term discussion. Tell them that this is how things are going to go, but keep short-term goals. Now, for a person who has a child 5-year-old, to envision what will happen at 20 becomes too much for them. So have 3-month goal. Okay, this is what we want to do. Maybe 3-month follow-up. This is how we'll follow up, and have that kind of communication and important discussion. First of all, tell them how they got there. So if they know that this child was already at a higher risk of getting myopia because of the parental history or the ethnicity or excessive near work or limited outdoor time, they know where to start making the changes, and educate them that what is progressive myopia, and tell them what makes this child more likely to progress. So then the parent actually knows, okay, where should we start? And as Dr. Jethani said, define the disease. Now, whenever you're talking to the parents, let us define what do you mean by myopia progression? What amount of axial length monitoring are we talking about? So they know, again, what they have to see too when they come for your visits. Another important thing is to recognize which parent is in denial. Now, all of us, when we see this, we see both the couple actually crumbling. You see the father blaming the mother, mother blaming the father, and there is a completely different game happening there in front of you, and that is when you stop. You think, do not counsel today, let this news digest, give them another appointment to come without the child, and then maybe go ahead for your parental counseling. So identifying where not to counsel is also important. This is very important in our practices, especially in Indian families where there is, you can't just say it is because mother is myope or father is myope that the child got myopia. This ends up in our urban households that we are seeing, it ends up at a very big fight there inside the house, and the real problem of this child having myopia is aside. So always bring this that it is nature and nurture. It is like diabetes, where the Asian population is anyways at higher risk, and then these are the reasons, so that there is a positive outlook to what we are looking at. avoid these scare tactics. I have seen it's like, you know, in the like how some hospitals, what we see for cataract counseling, where they say that this is bad cataract, tomorrow it has to be operated. So many a times myopia counseling ends up with these words like blindness, irreversible, we can't do anything. Please avoid these words completely. There is no need for scare tactics. Do not give so much of deluge of information when you are talking to parents about myopia. Let's go stepwise. So like I said, let's define myopia for them. Let's define progressive myopia. Let's do what is the risk assessment for this particular child and how we can help in making tailor-made approach for that particular child. Now, this is very important. As a parent, we always want to do something ourselves. So tell them this is your do-it-yourself thing that you can do easily at home. Let the child get outdoors, adjust the reading habits, have better sleep for the child. So this is something where the mother or the father feels that they are actually doing something to change the myopia. So DIY is really good. These are terms that our families really like. At home remedies. What can I do from home? So like every mother in your clinic would be asking you about food, actually tell them what they can be fed to the child. And some mothers go to the extent of saying, can I have a diet chart? So just give them something. See, you know it's not going to harm or really kind of change anything main, but for a parent to feel that, oh, I am feeding the right food for this child is actually very important. So go with this. Do not go directly into DIMS, HALT, atropine. Go for these basic things first so that the parent is with you. Practical tips. Now, this is at my own clinic where you see so many toys I have, but this child is with the phone. And so this is what is happening even at homes. So give them practical tips which you do with your own children. How you can set gadget guidelines, how you can have screen timeout, how you can lock your devices, how the parents can mirror good habits and have good family time outdoors so that the child doesn't get stuck with the gadget. Then you come to your science. So what you can do and all things that you can offer and how you are going to make this tailor-made for that particular child. So the parent feels that, okay, it is case-based, which is the truth. So you are not a salesperson. You are not here to sell those glasses. So remind yourself of that you are a pediatric ophthalmologist who wants to make a change. And let's always stock data. Let's not talk like a homeopath or an Ayurveda doctor where we are saying everything. Let us talk data. 20% improvement, 40% improvement with this over a period of time, what your studies are showing. Let's share that with our parents. And sell your skills. Like Dr. Jethani was saying, we already do this fantastically. You are going to, so sell these skills, tell them all these things like Dr. Shruti had shown, document it. What are you doing? How are you following up? This is again a very useful tool that I use. This is a BHVI has a lot of info available online, and this is a myopia calculator. So that particular age group of a child, if you enter this data, you will find that, okay, the progression can happen. So this data just shows you for a 12-year-old child who is starting at minus 1.5, at 17-year-old, he might get minus 3.6. So they have a prediction of how much this myopia will progress if you do nothing. And this helps your parent understand, okay, this is what we are looking at. Again, another tool is Ocumetra, again very similar, where you enter all these findings, you enter your axial length, and you get, so this is like, how does the patient myopia compare? How does the patient see the world? So this is again freely available, and you can use this. So this is how it is shown, where you will see the myopia and you will see, okay, this is how your child sees. So what are your options? Low dose atropine, bring in the ATOM2 study, give them a printed document, to take consents for what you are doing. This is again very important. Talk about how important it is to be consistent, and good parent motivation is very important. Some parents on the first go, they will tell you, because the child would have had a cycloplegic dilatation already before you saw. So they will say, no, I think putting drops is going to be very painful. So acknowledge that. Do not pressurize saying, okay, no, only this will work. Because you know the problem, if the parent is not going to accept that, the whole therapy is never going to work. If the patient has accommodation lag, so you need to document this, and you need to tell them that, okay, your options are now limited. You are going to be given either bifocal glasses or progressive glasses or multifocal contact lenses. See if the parent is okay with a contact lens being put instead of a glass. Then you can also teaching them what are we thinking about, what is this hyperopic defocus that we are talking about. With some models you can actually go ahead and teach that, and then advise about glasses. Like Dr. Shruti was saying, I also keep the model of these glasses in the hospital. So this is again another problem. From 4 years of age, the parent will be asking every visit, when can I do LASIK, when can I do LASIK, when can I do LASIK. Do not lose your cool. Tell them again to aim short term, and which will help. Do not stop treatment is something that we all need to tell them. And provide take-home information. Now, take-home information in today's world, if you give them pamphlets, they're going to be thrown right in the dustbin outside your clinic OPD. So video, or like Dr. Shruti has creating a WhatsApp group of these parents, making your connect with the parent much closer with your YouTube channel, Instagram, or your social media handles is going to really help them win, and then we all win. Thank you.
Thank you so much, ma'am. May I now invite Dr. Rashina Bansal, who's going to talk about myopia control marketing strategies, attracting and educating patients. Sorry.
Yeah, good afternoon, everybody. So I think my talk has been mostly covered by the previous speakers, but I'll just have a detailed thing on how we market. So the thing is, we are all talking about myopia control options for the last 2-3 days. So the main thing is, how do we reach the community? How do we approach them that these are the new options? Unless and until they have an information or knowledge about these things, they are not going to proceed further. So why market myopia control? This would indirectly help our patients to basically achieve and control myopia so that it doesn't reach a stage where they have ocular health complications in the later ages. If they have proper knowledge and we have outreach the community through more information, our chair time would reduce and the dependence on visiting multiple doctors would come down, and indirectly it improves the profitability of our own clinic. So how do we market? So there are two ways, either internal marketing or an external marketing. Internal marketing, first, when the patient has come to you who has a myopia, explain all the options available as the previous speakers have shared. Then the thing is that we can have our own WhatsApp groups, we can have our own team who is knowledgeable enough, from our optometrists to our counselors who know about the myopia management, so that at each step the patient is counseled about these things. So that's an internal marketing which does not involve that much of finances. Then the second option is an external marketing where we can involve PR, we can have social media things where we are putting posts, Insta posts, everybody is on digital media these days. So that has a cost obviously involved in it. So the first step is to create a myopia clinic. You have to ingrain myopia management in your own staff. You have to have a culture in your clinic that, okay, earlier when I was doing my MBBS or my post-graduation, we just took myopia as a normal refractive error. But as on now with the pandemic and increased use of digital devices, we are seeing that it's becoming a epidemic by 50% of population. So we should not scare the parents, but at least create awareness, and this will come through our own team and also the patient education. So our staff should know why this is beneficial to the patients and how we can grow indirectly our practice also through this patient education, and the patient should be given awareness about these clinics. So there should be myopia management signage everywhere. So our role should be not to sell our practice, but basically create awareness that there's something known as myopia clinic where we can handle this, and the myopia progression can be controlled. We can have posters all over. We can have photographs of the successful patients, or maybe take small videos and put it on our basically waiting room area, where the people know that these are the positive things which has happened when the child has taken a myopia control option, which will basically motivate the parents to ask us that what is this. It should not be that the person is reading on Google, or maybe a friend is telling, okay, Dr. Rashina is managing this, please go to her. That's another indirect way. But if we are telling this to the patient on the first hand, and they already have a knowledge about it, on the next visit they will themselves ask. They would have Googled, read about it, so they'll come back and ask, I want to think about this option. So they'll read about it and they'll be more assured to take that treatment. You should have brochures about myopia control management in the clinic. Then on my website, what I have done is I have the separate myopia clinic page where all the options are given, and click for appointment tab is separate, so that they can exclusively take an appointment for the myopia clinic, where we are exclusively doing the workup for the myopia management. Then parent education, as Dr. Aloka has wonderfully covered. The first message is starts when the patient is with you, the parents are with you at the first checkup. Make them aware about all these things, all the myopia control options. But as Dr. Jethani said, that should start on the next follow-up if we are seeing any progression, not on the first visit itself. So we should discuss this with the patients who require it, not everybody. In the waiting room where these options are already displayed, they will know that this is required when. Okay, so there are two types of things which happen. One, a parent will be there whose child is myopic, and the parent himself or herself is myopic. They already know what they are going through. Yes, so it's easier to counsel them, but the main question arises is, ma'am, when we are putting glasses, हमारा 18 साल पे रुक गया, तो अब बच्चे का भी रुक जाएगा. What is the need? So we should make them aware that with every increase in diopters of myopia, what are the ocular health implications? And if these options were with us earlier, we would have helped you also. So as Dr. Aloka said, we should resonate with the parents' thoughts. Yes, we should understand they are not in that anger mood. They are trying to understand. So the amount of counseling should correlate and resonate with their basically expressions and the way they are talking, what we need to understand. And the second is, the parents are not myopic. Their major concern is that none of us have glasses in the family, why my child got it. Yes, and they will not know what their child is facing. I see that first time a child comes 5 years old, -8 myopia, they say my child is able to pick up the smallest of thing. Yes, and you are saying he or she has -8. How do you assure them? So what I do is I make one of the parents sit. Yes, the one who is more apprehensive is generally is the mother, and put the same plus power on her eye and tell that this is most probably what your child is looking now. Your child doesn't know from birth till now what the child is seeing is good or bad. Unless until we make them wear glasses, we can't make them realize that this is the actual world which they need to see. So that assurance is needed, and then they will realize that, okay, yes, this is what I have to go through. So this is how we make them realize that this awareness is required. Then I have a lot of information packets which I provide as referral forms, journal review articles with QR codes of all the latest management options, which I generally, in my vicinity, all my pediatrician colleagues and also opticians, which I provide, so that they know that, okay, that if they have this, whom to approach. Yes, there are lens brochures about the latest treatments and the management options. We should also have something, maybe as Dr. Aloka said, digital media. Yes, so this all should be there on your website, where frequently asked questions. मेरा बच्चा कैरेट खाने से उसका नंबर कम हो जाएगा, उसे चश्मा हमेशा पहनना पड़ेगा कि नहीं. So these type of questions should be answered there, so they have the information pre-hand, and then when they come to you already, they have read about it, and then doing the counseling is much better. Then e-blasts. any person who is basically come to you who has a refractive error, and we have explained them these options on the second follow-up when we have seen a progression, and they've still not opted for treatment, I tell my optometrist to keep a record about all these. We send them emails. When they read about it, then they maybe come back to you next visit and ask for you for these options. Then lot of blogs, keep writing blogs about the myopia control management, also video logs. If you have a YouTube channel, as much as you can give information and create awareness, it will be good. Then I have my own Instagram channel where I keep posting all these things about the newer options, what is myopia, then the common questions asked, that supplements will help, not help, what are the latest treatment options, screen time guidelines. So all these will help. So to take home messages, multiple communication channels are the best. We have to build trust in our patients and not sell our practice. And education of parents is the most important thing, where we are not scaring the parents, but creating awareness about the progression. Thank you.
Thank you, Dr. Rashina. Again, great tips there, and I loved the colors and the things that you use for your brochures. They're excellent. The also the concept of sharing the brochures with all the pediatricians and opticians around your hospital is a great tip. So we go next to Dr. Aditya Sethi from Mumbai, integrating telemedicine into pediatric myopia care. Please, sorry. Yes.
Basically, I'm not a pediatric practice, but sometimes patient comes to me having high myopia, like this post-COVID. So one of the child somehow shifted to stats, and she started with -6. Hello? Yeah, she started with -6 when she was 4 years old. Then she left when power was almost 8.5 or something. I started her on atropine, topical 0.01%. But when she reached there, their pediatrician prescribed 0.05%, and that also in the daytime. So the parents complained to me that the child is having blurring of vision, and so I didn't have the idea that what to say, because here, as I know from all of you, that it's been 0.01% and bedtime, and morning, that time child was very comfortable, did not complain of anything, haziness. So what is your take on that? They told that without this 0.05, it's not effective at all.
Yes, the morning and the night dose is only for our convenience of putting. There's no blurring of vision even with a 0.01%. The night dosage that we are giving right now in India is only so that everybody sleeps at almost the same time. So bedtime dose is easier for the parent to remember and put. But you are right, 0.05 is what is available in the US. US FDA hasn't approved of 0.01, and there is a recent study which has been published on 0.05% in India. We are seeing excellent results, and I think in the coming years we will be treating pre-myopes, mild myopia, moderate myopia in a very different format, and we might have different percentage for different zones of myopia. So 0.05% has been extensively studied now in India also, and I think we'll be having a release.
Just to add, just to defend them a little bit, they just recently published a study where they said 0.01 has no effect in their population. So that's why they are starting with a higher dosage. That is coming up, their results are coming up, so that may or may not work as well. And very few population do have sensitivity to or photophobia to even 0.01%. That's a very minimal population. In those cases, what I generally do is I add on DIMS or any of the myopia glasses. They've come with a photochromatic ability. So when the same patient is on atropine and is on DIMS, when they go outside, their glasses become automatically more sensitive for light.
The second part of the question was that they told that this doesn't work when it's given at night because the child is not using the eyes. So when he or she will accommodate, then only the thing is going to work. So better to use it.
That could also be hearsay, ma'am. If the doctors directly said that to you, then we can take this question. Otherwise, it could be just hearsay through the parent. Sometimes
No,
The
I
way you
think to
understand.
defend there, the problem is all of this is still being prescribed. I don't think they would have landed in US and got a pediatric opthal appointment,
Yeah,
to be
every
frank.
pediatric
It
optometrist.
usually ends up with an optometry practice where there are a lot of controversies between the optometry world and the opthal world there. And so a lot of misinformation happening because of that crossover. But yeah, there are no studies saying that.
I have read one study where actually it's been documented that if we are giving the daytime dose, it works better. Yes, but in our Indian studies, whatever we have done, even Dr. Rohit Saxena has compared that, but we've not found any difference in the daytime or a nighttime dose. But there is a study, I really can't recollect the which year, but it was, I think, in the last 2-3 years, there's a study where this has been compared, but not in our Indian population.
Okay, so I'm going to talk about integrating telemedicine in pediatric myopia care, something which is very new and something which has literally zero studies. So basically, till now we've been talking about how to handle myopia in your clinic. But the real question is, how do we get to those patients or those children who have myopia and are not coming to you because they don't know they have myopia? And that is where the impact is. The problem is the burden of myopia is just going to increase. We've all seen this slide numerous number of times, and the reason it's out there, every speaker is talking about it, is just because we want to spread awareness that this is actually a problem, and this problem is going to just capital weight. So what is basically happening is this study which came out from Sydney, which said that by 2050 every second child will be myopic. I'm pretty sure the stats have changed and it's much more now because of COVID and being indoors for so long. And if you notice, the burden is more so in Southeast Asian countries in Asia. So like our previous speakers have pointed out, that Asian population is any which way more inclined to have myopia. Of course, one of the reasons are because of newer activity, more population, more indoor time. All of this leads to more myopia, the burden myopia more so with us. And as it progresses, we've already had a slide which showed how dangerous it can be and how you can have RDs, you can have glaucoma. And the less spoken about is the economic burden. Every child will require a glass per year at least, and that costs the parent and that costs the manufacturer. So the whole burden on the economy, it goes up much higher if you have more children wearing it and more glasses coming out which are more expensive. Things are getting more out of hand. So how do we target them? How do we manage them? That's where teleophthalmology comes in. And teleophthalmology, telemedicine today, it doesn't come alone. It comes with AI. So the conjunction between both of them is very important. And ophthalmology being a very image specific, everything we do is image specific, OCT, fundus photo, whether we do a diffraction, that's data. So all that data, that image together, if it's incorporated, that makes great for AI. Like that's all AI needs. So that's what we are talking about. That little zone which is undiscovered, which can serve the underserved population. So what is basically telemedicine? Telemedicine is basically getting remotely delivering health services to an area which does not have the health services or is not coming to you. It's as simple as that. So you're allowing patients to receive medical care who will be sitting, say, in some remote zone from here in Calcutta. So that's how it works. So key components are a good digital communication platform, remote monitoring devices, EMR or EHR that you may have, and a patient management system, because you don't want to lose this data that you're going to get from them. You need to show and you need to spread awareness, as we've been talking about, let them know what myopia is, sensitize them, then give them the treatment that they need and they will benefit from them. And the benefit is cost effectiveness. Number one, you have to make sure that the economy is correct, and this is the best way of making your practice sustainable. Number two, improved access to care. Now you have a target audience. You can now send the message to them that, okay, if you need further treatment, you can come this way, rather than them coming all the way. Like literally nobody goes to travel 200 kilometers to find out if they have diabetes. Nobody goes 200 kilometers to find out if they have myopia. So once they're told in their school by a school screening, or they suddenly realize, then they come to a doctor to check. That's been the urban situation. Now, when you put it in the rural side, when no school screening is happening, they may or may not know. That is the question mark. How much percentage is actually underserved? That's what we have to answer, and with that comes telemedicine. And the advantages of the effectiveness will be seen in the next few years. There's a lot of studies on it as far as diabetes is concerned, glaucoma is concerned, but hardly any work being done in myopia. So need of telemedicine by direct myopia is very, very evident. There's a rise of prevalence in myopia. So if there's a disease, there's always an opportunity. The opportunity, then we have to do it. Challenges in traditional care access. Now, like I explained, not everybody can come 200 kilometers, 300 kilometers and find out if they have a glass number or not. We may assume that there's a optical shop or an optometrist in every zone, but that's not true. Impact of COVID-19 has made all the telemedicine part very popular and very effective. People, the governments have spent money on teleophthalmology, telemedicine. There are now bodies available which can guide you through this. And telemedicine has come out as a actual solution now. And there's evidence in various suggestions and evidence in various articles which say that, yes, it can be used in myopia. So benefit of telemedicine is again increased accessibility. It makes your work more achievable. It makes your target population more sensitive. It tailors to your patient with AI in between. It even make it more patient specific. And it's time saving, and then you have a lot of family engagement because you can spend time doing chair time. Like suppose if I wanted to speak to the parent, but I don't want the parent to be sitting in front of me, I can schedule a Zoom call with them. They come to that telemedicine department in that rural outreach, and I have a face-to-face with the parent right there instead of me taking a train or them taking a train and coming to meet me. So yes, it is, advances are there. And with the current scenario of having 5G and more accessibility, I think it's going to be more and more important as time comes. You have a lot of digital vision screening tools now available. You have smartphones which can find your refractive error. You've got the plus optic devices, the photo screeners, everything available already. And easy to transport, easy to scan. We have a lot of Arvind-based projects already there which are doing this. You have wearable devices now. You foresee a lot of, we already have cameras in our glasses. It's high time we may even have other methods of finding how sunlight is being tracked. Dr. Shruti has worked on a wristband which works on finding how much of ambient light or sunlight the child has been going. So all this data can be accompanied to find out where the child will be tomorrow, where will his myopia be. And this is all AI and machine learning, and that's where it all works. And there are a lot of question marks on legality of it, the data, where it will go out or not, and that's being answered slowly. The key here is to make it more transparent, that everybody knows what's happening, the parents know. Like ma'am said, take consents, and that consent can be in local languages, and maybe a Delhi doctor can treat somebody who's in Maharashtra. So that may happen, and that is how we foresee the future of telemedicine and ophthalmology, and let's see how it works. And a lot of research has been done in different streams, and we are now more inclined to using this as a platform of reaching the underserved, so that may work. Of course, there are a lot of challenges and limitations still, and there are a lot of questions about security concern, privacy, which has been slowly answered. And before I wrap up, just a few more slides about myopia management. Now, all we need to know is the important data here, whether it's the axial length, is it increasing or not, where you have now more portable ways of measuring the axial length, A scans, and your new softwares and smartphone apps also coming, which can help and find out exactly what the spherical equivalent is and how much the axial length is, and that can be used as data, and that's exactly where you bang on hit and find out what child needs what sort of prescription, and what child needs atropine, what child needs myopia control glasses, and how to go about it. Because all this data can be used, summarized, and then given to you, and then when you're having that chair time with them online, you can deliver the same. So a lot of new wearable apps are now available. You have new glasses coming out. Apple is coming up with a glass which is going to measure ambient this thing. Maybe there'll be an app which adds to it and find out an axial length by just wearing glasses. You never know how the future is. And in conclusion, this is an undiscovered zone, and it is, I feel, the future of pediatric ophthalmology. Maybe not now, maybe in 5 to 6 years, but we all have to be aware and use it at the right frame, at the right place, because India, like I said, has a great population, and that great population requires us to be more diligent and aware of the future. Thank you.
Excellent talk, Dr. Aditya. And the integration of AI into telemedicine is looking at exciting horizons ahead. Anything specific that you feel you have used or you've seen somebody using for myopia diagnosis, like diagnosing
Yes.
myopia in telemedicine?
So the IDX DR platform and the IART platform, which is basically used for diabetic retinopathy, can pick out images and talk about pathological myopia or early myopia changes. And what basically is happening now is there's a study which is going on where using a fundus photo, they're trying to find out if this child will have a progression of myopia or not. And that, I think, makes it a little more sensitive as well, even more than axial length.
Also, I think, this is not exactly telemedicine, but it can be, and it has been integrated and published, is again the red glow and, teaching your pediatricians on their vaccination schedules to do the red glow assessment and kind of picking up children with refractive errors is again something which we need to talk more in the pediatric conferences and teach the practicing pediatricians of your cities to diagnose. And again, it's a telemedicine tool where even photographs can be analyzed for the asymmetry in the red glow. So, yeah.
Truthfully, ma'am, we have very few pediatric ophthalmologists who are trained. So by use of telemedicine, we can have non-pediatric, even non-ophthalmologists who are trained to take these pictures,
Exactly.
sent to a
So
center.
that's what pediatricians, exactly, the
I
child
think
specialists.
in our community, how to reach the most important thing is that the pediatricians should be educated about
Absolutely.
it. They, at each visit where the child is going for any vaccination or any regular flu checkups, or there should be a system where at least their visual acuity is determined. Yes, or they should be guided that if the parents have glasses, then please get your child's first checkup done at least by 3 years of age. These have to be basically more, the pediatricians have to be made more aware. So I have involved myself in Delhi in the Delhi pediatrician group. We have a lot of groups there where I go and give talks on all these,
Awareness.
and that indirect give me referrals also, and then the parents are also educated through pediatricians. Yes, so they are more aware and they know about these things happening around.
Okay.
I think we'll go to the last talk for the session, which is community outreach.
How will you find out if a myopia? The
So
AI
the-
data? That's what you're asking about?
The definition, sir, would be more than -6.
Patients come with -3, -4,
Yes.
and everything is okay. After correction, vision is okay, 6/6. Then how we sense before
Yes.
myopia may worse.
Yes. So there are certain
What are any
Yes.
data for
Yes.
progression, myopic progression data?
So that would come when we have baseline axial length for all your patients. When you see that patient coming for the first time having a -3 glasses, documenting the axial length at that time and then following it up, say 3 to 4 months later, or 6 months, and every 6 months, if there is an increase of more than 0.5 diopters myopia, or there is more than 0.2 millimeters increase in your axial length over a year, is defined as progressive myopia. The other sense factors that you can have is if the one of the parent is high myope, or the child has started with a higher myopia like -3 at a younger age group. Say the child is only 5 years old and has a long way to go compared to a teenager of say 14 years old, and if he is -3, then the rate of progression or the time that we have for progression is much higher in a younger child with high myopia. So those are the two very important prediction factors where you can say. And then special children, again I think that's a very important group where these children are not outdoors because of lot of social stigma. Most of the special children, the autistic, the ADHD children are indoors, so less sunlight exposure, and to manage their behavioral disorders, more screen time. This is the target group which ophthalmologists are finding very difficult unless you are good at your retinoscopy. So that is a point where these are the sense factors where you can say, oh no, this can progress. So I think that's an important take-home message.
I have a question.
How should be the
And,
follow-up time?
So every 6 months,
Not
first
before
you
that.
do a early, you do a maybe in 2 or 3 months, check for the axil length, then 6 months, and then you do it thereafter. If you actually can predict that the axil length is increasing, ma'am showed a very good tool online also. You can put your data there if you want. Otherwise, if you can see the axil length is elongating, that means the child is going to go into myopia progression. That's where you have to intervene.
In your clinical observation, how much axial length in myopic progression in every 3 months? Have you any clinical?
Uncontrolled?
So every 3 months we really don't do or document the axial
Yeah,
length.
yeah,
Every
yeah,
time the
yeah.
parents will not be.
I think that.
Yes. So see, the early age the child is presenting, the higher the myopia, and the third is how the progression is will determine whether the child will have pathological
Axial length we
myopia.
can calculate by a scan.
A scan. So see, most of the people don't have optical biometry or non-contact axial length calculations like the optical biometers. It's really not for general
A-scans.
A scan can
Basic
be
A-scan can
enough.
do it for you.
Yes, so we can do on A scan, but there may be a little amount
Have
of
you any
standard-
clinical ideas, non-madratic axial length calculation or madratic axial length calculation
No,
differ?
axial length will not differ on
Not differ.
pediatrics.
Does not differ.
No, no.
Does not differ.
Yes.
Now I have a question that up to which age you will recommend that Kitro or 0.01% atropine? Up to which age?
So yeah, stopping is I think the toughest part here. Usual recommendation right now is at least give for 2 years, see how the progression is, stop if there is rebound, restart. I am seeing if we are starting say at 10, I'm seeing at least 6 to 7 years of atropine being used actually.
I am saying that I am general ophthalmologist.
Yes, sir.
But I have seen that pediatric ophthalmologists vary in their opinion regarding
Yes.
the
There's no
duration.
strict guideline.
Like
but
in
2 years
medicine,
minimum.
everything
yeah,
is
yeah.
grey, sir. And this in the grey zone of medicine, the criteria keep changing. Right now, what we are all following and what we are supposed to follow is 2 years of low dose atropine. If the child is still not, is still progressing, continue atropine forever and till 18, of course. And or else, if the child is controlled, stop atropine, reassess after 3-4 months. If you see a progression of myopia happening, restart the atropine. For lack of availability of higher dose of atropine, we also go for twice a day 0.01% atropine in the children who are not controlled by low dose atropine. Any
Yes,
other?
so we had a discussion, lot of discussion on this. So even few of the pediatric ophthalmologists we here as a team have discussed about that. We don't abruptly, suppose the child has taken for 2 years, we don't abruptly stop and wait for the we gradually taper.
Gradually.
So initially till last year, I think I was following that abruptly stopping atropine after 2 years, and I saw a lot of rebound happening. Yes, from last year, since the time I have started doing a tapering dose, like first give everyday dose, once a day dose, then start giving alternate day, then twice a week, and then once a week, and slowly taper off over a period of 2 to 3 months is what I am following. And till now, I have not, so it's just 1 year. I'll eventually know how the rebound, whether the child is showing or not. It's still a big question, but that can be done. So we're still
Okay.
studying all this.
Okay.
It's all under.
And one other question, that is exactly not related to it. That in my setup, I saw many patients now it is 24, 25 years of age. Still, they have power refractive error is not controlled, and I observed it within the last 3 years or so.
You're absolutely right, sir, in your observation.
It was not seen earlier.
Absolutely.
But on the part of patient and parents.
So I think this is again something which needs evaluation. We are seeing even in the early 30s progression of myopia, something which we used to never see. And I think screen time in adults also needs to be evaluated.
It's all screen time, mostly excessive near work, where we are all into digital gadgets and everything, which is causing all these problems. We still need to study further about these factors.
So we'll go to the last topic for the day, that is community outreach and school-based myopia screening programs by Dr. Prachi. She's not here, but she sent a presentation.
A very good morning to one and all. At the outset, I would like to thank Dr. Jethani for including me in this IC. I'm really regretting missing the physical meeting, but I hope to do my share by contributing my talk. So I'm going to talk about community outreach in myopia. So my talk is going to be based on a few W questions related to the community outreach. So that's going to be the mechanics of my talk. So let us begin with why. So why is myopia a problem at all? So we need to understand that it's an important public health problem. The rate of myopia among high school students is reaching as high as 80 to 90% in some Asian countries. It inversely affects the quality of life and can cause a huge economic burden on the society. The WHO has estimated 19 million children to be visually impaired, of which 4 million are blind. In India, 0.8 per 1,000 children are blind. Half of the causes of blindness are preventable or treatable. In India, 270,000 children are estimated to be blind, and refractive errors forms the commonest cause of visual impairment outside the blind stage. So in the blind stage, it's the corneal and the lenticular opacities which are the common causes for the blindness. So as we know, myopia is increasing at a hugely rapid rate. Half of the population is estimated to be myopic by 2050, with around 10% of the kids having high myopia. So why do we need to control myopia? We now know that there is a high incidence of ocular morbidity and visual disability with higher the myopia, higher the chance of retinal issues, risk of glaucoma and cataracts, and also it involves a high cost of optical correction. Hence, screening for myopia can facilitate early detection and help us implement a good management to try and prevent the progression of myopia. So how do we go about addressing this problem? The how is going to come again. This question I have divided in two parts. So how do we deal with this problem? So screening is something which is a very effective means of tackling it. The definition that I have put on the top is a WHO definition and a bit complicated. A simple way of defining screening is a relatively short examination that can indicate a vision problem or a potential vision problem. So when do we conduct these screening camps? Well, you're okay to do it throughout the year, but as per literature, it is stated to be from April to September, because mainly the load of cataract surgeries increases from October onwards. However, if you have dedicated people to do the school screening or team to do it, you can do it throughout the year. The only thing that you need to take into consideration are the children's vacations and their exam schedules. So where do we really go and conduct these camps? So the centers that are to be tapped are the schools, the community centers, at community events, and sometimes in in-house clinics. Now this has a dual advantage. First, we can identify the kids who have a problem and help in their referral and treatment. Second, this can also act as a small marketing tool for the center and the services that are provided by the doctor, and create a better name in the community and in the neighborhood. So whom? Now whom is the screening done by? So it is generally the teachers, the optometrists and the ophthalmic assistants. So in India, the commonest approach has been through training of school teachers who do the initial vision screening and refer patients with suspected abnormal vision. In some areas, all the school teachers in a particular school undergo training, while in some other schools, there may be a few select teachers. The advantage of training all teachers is that the class teacher can themselves administer the screening and the students tend to be more comfortable with their regular teacher. The community screening camps can also be conducted at primary health centers during some community gatherings, as in during Ganpati or some Navratra, or as a part of a health camp in a particular area. The ophthalmic assistants and the optometrists are the backbone of this screening. The tests that are done during screening include an uncorrected visual acuity estimation, which can be accompanied with an auto-ref reading or a photo screener. In some settings where there are stay cams, a cycloplegic retinoscopy or auto-ref is also done, and the glasses are dispensed at the same time. In some other areas or probably in-house clinics, we can further our camp services by including a biometry as well. Now, in all of these models, the essential parameter for success is provision of spectacles. All our efforts are futile if this is not looked into. Most commonly, the children are prescribed the correction and the glasses are made available for designated optician. In some camps, the organizations may dispense the spectacles on the spot. Now, whom is the screening done for? So, the pediatric population is subdivided into three age groups: 3 to 5 years, 6 to 9 years, and 10 to 15 years. For myopia specifically, the screening is recommended from 5 years onwards. However, certain screenings are also done in Anganwadi camps where probably a photo screener tends to be the most useful. While the screening tends to be the most successful in the 10 to 15-year age group because the kids are more aware, they can vocalize that they are not seeing well and can ask for a proper referral. So again, we come to the second part of the how question as to one, how was the screening program initiated and how is the actual screening done at the campsite? So the National Program for Control of Blindness had initiated the school eye screening program in the year 1976. This is primarily administered by the respective state governments in collaboration with the district health authorities as well as through public and NGO institutions. The school eye screening program has become an integral part of NPCB since 1994. It was initiated after successful implementation of a pilot program in 5 districts, which was again a school teacher training program. The actual planning of the school eye screening is done by the respective district health societies. They look at various parameters like holidays, examination, involvement of teachers, availability of human resource when they do the planning on a large scale. So what is a school eye health program supposed to consist of? To identify children with refractive errors and dispense glasses, educate them about the eye condition and eye health, provide primary eye care for children, and have a school environment that promotes good health. The school eye screening program in India, as we talked earlier, the teachers and or the ophthalmic assistant visit the school. They have been given with a toolkit which includes a measuring tape, a visual acuity chart, referral card, and educational material. One thing that I would like to state is basically the advocated vision card is the e-optotype card because that can be randomized. The other Snellen acuity cards can sometimes be by-hearted by the kids and may not provide us with the accurate referral. The teacher indicates a subnormal result when the vision is 612 or lesser, or also in case of a doubtful response. In the era of smart age, we have apps which can be used for school eye screening. So this is a peak vision acuity app, which is a simulation tool which can actually compare the child's vision to clear vision, which can be printed and be handed over to the parent or the caregiver. So in this app, you can just download it from the Play Store. It gives you a tab for calibrating it. You need to measure the height and width of the arms of the E. Once the calibration is done, you need to measure the vision at a distance of 2 meters, 1 meter and 30 centimeters. So a string of those lengths need to be carried at the campsite. The app gives you the vision, which has to then be compared, which then gives a simulated result against a normal vision, which can be, the report is then shared with the stakeholders of the camp and the report is passed across to the parents for appropriate treatment. Now, what really goes into planning this screening? So there's this module called as a Sahara survey module, which is School Eye Health Rapid Assessment Tool. So this is one way of actually planning the screening. So it gives us a scale or a survey to how the camp should be planned. So the step one is estimating prevalence of visual impairment in school children in each global burden of diseases region. The proportion of children requiring eye services is estimated. Then a cluster survey design is used with schools being the sampling units. The sampling stream of the schools is attained from the relevant authorities. Then the further cluster nature of the data is collected. So this is some correction factor for allowing the loss of variation in the sample. The sample size calculations for different global burden of diseases region is done. The prevalence range is considered to be in the range of 4 to 19% for school children across the globe. This then goes through stages of, once this is conceptualized, the stakeholders are interviewed, then there are advisory group consensus meeting, then an output is formalized. So this is how is the actual planning that goes into designing these school eye screening programs. So the main people who are actually very active in this is the site savers who have a program called as the Vidya Jyoti School Eye Health Program, and the RBSK, which is Rashtriya Bal Swasthya Karyakram, which provides free treatment from birth to 18 years for 4 Ds, that is defects at birth, deficiencies, diseases, and developmental delays. The final recommendation include that the children should have annual school-based vision screening throughout the childhood and adolescence. Screening up to 5 years of age can be integrated with the universal immunization program of the government, and beyond the age of 5 years, it should be a part of the annual school health checkup. Thank you very much for a patient hearing.
Yes, I think we had a great talk by Dr. Prachi, and the importance of screening in our communities when we are doing cataract screenings, and extending the services to the kids or grandkids of these patients would be a great idea too.
Yeah. So, if are there any questions? Okay. Thank you.
Thank you. ये शादी का फोटो से ज्यादा